Hi everyone, this is our Endo DM and GI lecture. A lot of this is just a progression of what we did last semester. Let's get going. In our Endo, we're going to talk about SIADH versus DI. So SIADH is the problems all come from the pituitary gland, and the SIADH is an increase in antidiuretic hormone response. So if we have an increase in antidiuretic hormone, then we retain fluid. We're going to have excess fluid volume. We're going to decrease our urine output, or it's going to decrease because we're keeping it in the body. We're going to have increased edema, increased blood pressure, but our sodium is going to be low. This is the problem with both of these, is the sodium. So if we have hyponatremia, it is because it's diluted. It's diluted with the fluid, with the water that we have in our system. Okay. Now, with diabetes insipidus, nothing to do with diabetes, it is the opposite. It is low antidiuretic hormone in the system. So if we have low antidiuretic hormone, then we have an increase in urine output. Therefore, we have a decrease in fluid volume. So we have fluid volume deficits. We're dehydrated, we're thirsty, we have low blood pressure, and now our sodium is high. We have an increased sodium in our serum. That is also a problem, so we're going to have to fix this. So chances are we're going to have to dilute this somehow while fixing the problem, and we're going to have to increase the sodium slowly. Both ways we have to do sodium very slowly. I have the amount written below. We think of sodium Na, N for neuro. So you're going to see some neuro changes possibly. Okay. And N for neuro, if you adjust that sodium too much, you're going to notice a cerebral edema, and then you can have neurological issues, neurological problems. Okay, so first we're going to go to diabetes insipidus. So remember, we have low ADH, so we have an increase in urine output, decrease in fluid volume, and so on. Okay, again, not concerned with diabetes. Happens in the posterior pituitary. It can either be acquired or it can be due to medications or renal disease. Sometimes with renal disease, we have a lack of response to the ADH by the kidneys. Okay. So we want to do a couple of things here. We want to, we have bloodstream loss of water, concentrated sodium, hypernatremia, polyuria. So with that increased sodium, we can't give them normal saline. So what we need to do is give them water. And one of the few ways that we can give them water straight into their IV, if they are not able to, if they're too weak or confused to swallow, would be D5W. So this allows us to put water straight into their veins as D5W to dilute the sodium. So as we're trying to figure out what the problem is, we need to slowly dilute that sodium to cause less problems. Now, our primary goal here as well is to replace the ADH because we don't have enough of it. So that we're going to do with desmopressin, which is DDVAP, and it replaces the hormone. Once this starts working, you should notice a decrease in, you should notice a decrease in urine output. This is a fine balance between your D5W and your desmopressin. So as you notice the sodium starting to come down, then you might want to stop the D5W. This is a fine balance with the sodium, not too fast, not too slow. Okay, if the blood pressure is is very low, the desmopressin might help a little bit. If not, we can go ahead and give them vasopressors to try to increase the blood pressure while we're trying to fix the problem. Okay, this is definitely an intensive care patient due to the minute changes and risk of problems due to cerebral edema and sodium neurological problems. Indomethacin, you don't hear that very often. A lot of the drugs that we're talking about today are also off-label. They're used for off-label. So an NSAID for inflammation is called indomethacin, which we haven't spoken about before. The mechanism is unclear. However, it helps with our diabetes insipidus. It helps the ADH hormone. Okay, and like I said, the mechanism is unclear. Okay. So I have this again just so we can remind ourselves. SIADH, increase in antidiuretic hormone. Fluid volume excess, so we're retaining fluid. We're not urinating. We have edema, we have high blood pressure, and we have a decrease in sodium. Okay. So this particular disease, SIADH, is typically caused by brain injury. It can also be triggered by neurosurgery. Okay, so we have hyponatremia, hypoosmolarity of the blood. Oh, I don't know where that went. It's way down there. Okay, so the patho for SIADH. ADH is obviously essential for fluid balance in the body. So ADH stimulates reabsorption of water at the collecting duct of the nephron. So it causes excess water reabsorption into the blood. Increased water in the blood causes hypervolemia, dilutional hyponatremia, and then concentrated urine because we're not urinating very much at all. Okay. This is a nice diagram that I found showing you how the urine volume decreases, urine osmolarity increases, urine sodium increases, so I would assume a urine test would be good here. Increased blood volume, hypoosmolarity, dilutional hyponatremia. Okay. And we can get irritability, confusion, hallucinations, seizures. Okay, so all of the problems that we have when we have neuro issues. So our treatment for SIADH is to replace the sodium slowly. Okay, slow, which is 10 to 12 millimoles per liter in a 24-hour period. That means you're going to be taking, you're going to be making sure that there's an order for frequent sodium labs, and you are monitoring those sodium levels very, very carefully, counting how much noting how much the sodium is increasing, if it is increasing, and calling the doctor if you feel like it is starting to increase too much. Okay. Fluid excretion. What that means is we want to get rid of some of the fluid. So if we give them furosemide, for example, that will increase the excretion of free water. So if we put a hypertonic saline in there, which would be 3%, which is for sure only used in the ICU because it's 3%. If we use that, think about the way albumin works. So if we use hypertonic saline and we give them furosemide, the hypertonic saline is going to pull that fluid that they have, their edema, their intracellular fluid into the vascular space, and then we can flush some of it out with the Lasix. Okay, so that ICU only. Okay. The tetracycline, we can use it. It has a unique effect used to counteract SIADH. Sometimes they'll use that as well. And then what we want to use is we want to fluid restrict these patients because they already have low sodium. So we need to restrict the amount of fluids, and that means all fluids: juice, coffee, tea, water, anything. Okay? We want to do that in order to try to concentrate their sodium in their blood a little bit. So we have to do that by dehydrating them a little bit. So what we want to do is decrease the sodium restriction, possibly give D5, normal saline to try and help increase that sodium slightly. This is going to be very, very slow. And then if that doesn't work for some reason, then they can go on these medications. Now, these medications are very potent, not to be given for more than 30 days due to liver damage. So they are not the first line of defense. Okay, and we'll talk about them below. So we're going to limit the fluid restriction. We're going to limit the fluid. However, we're going to increase the sodium, and it's going to be done very slowly. Okay, so as you can see here, I have this little graph. So if they have severe symptoms, then and sodium of severe, which is sodium less than 125, we're going to give them that hypertonic solution with that furosemide, followed by fluid restriction. Okay. If it's moderate, which is less than 130, we're going to do fluid restriction and Vaptan. Okay, and these are the Vaptans right here. If it's mild, which it typically is, especially what you might see, which is less than 135, then we're just going to do fluid restriction. Okay, so this is kind of a little algorithm that we use for severe to mild hyponatremia. Okay. Okay, so we're going to, just to kind of reiterate, we're going to increase the sodium by sodium chloride, IV infusion, or we could give them sodium tablets if that's appropriate. We only want to increase the sodium by 10 to 12 millimoles per liter in a 24-hour period. Okay, right here. We can take some of the excess free water out with Lasix and using a hypertonic saline. Okay, so that would be 3%. So we're increasing the sodium a little bit, but we're taking out the free water. Tetracycline is sometimes used, and then the Vaptan medications are only used if the fluid restriction does not work or the hypertonic solution does not work. Very limited on the use of the Vaptan medications due to its side effects. Okay. So diabetes, DKA, most common side effect of diabetes. So it usually only occurs in type 1 diabetics because of the absence of the endogenous insulin, right? Type 1 diabetics do not have endogenous insulin at all. They don't have any circulating insulin in their body that is made by their bodies. However, type 1 diabetics that have pump therapy rarely go into DKA as long as their pump is working because of the basal insulin that they're getting. Okay, it's kind of an important thing to note, as when you go into the hospital, you're going to see more and more insulin pumps. Type 2 diabetics rarely go into DKA, rarely, but they can. And that is if they have pancreatic beta cell failure. So there are some type 2s that go into beta cell failure. And so at that point they can, they're still classified as type 2, but they can go into DKA. But very few of them do. So as we know from last semester, ketones are formed from lipolysis, which is the breakdown of fats that release fatty acids. That's ketones. If insulin is not sufficient, the intracellular glucose drops, and so then the catabolism of fat for energy is produced by these fatty acids. Unfortunately, if we have an increase in ketones, these fatty acids that are released into our system, then we have ketoacidosis. So, because they're fatty acids, so they're acidic, and so now our metabolic body is now acidotic. They accumulate in the blood, alter the pH, causes the metabolic acidosis. That's when you're going to have the Kussmaul's breathing, the sweet breath smell, all of that stuff, polyuria. With the metabolic acidosis and the ketones, they get profound dehydration. So as we know with regular diet, type 1 diabetes and type 2, that is a normal side effect of increased blood sugar is polyuria. But with DKA, it's like it's exacerbated. So we're going to get profound dehydration. We have severe hyperosmolarity. That is intracellular fluid loss in the brain, which could cause a coma. Mortality rate when you're talking about a coma from cerebral edema is about 70%. That typically, the majority of times that happens, unfortunately, is on first diagnosis of type 1 diabetics. If they are compliant and trying to work on their diabetes, chances are they won't go into DKA and therefore they won't get the cerebral edema. That is all caused from a fluid shift. Okay, so in regards to DKA, there are some values here that we need to know. So in order to be considered in DKA, your blood glucose needs to be greater than or equal to 250, your pH less than 7.3, your bicarbonate less than 15 milliequivalents, and ketonuria, so ketones in your urine. Okay. So think about this dehydration. There's a lot of talk about dehydration and fluids today. So if the patient has profound dehydration, then their potassium levels are going to be falsely high. Okay? So the hydrogen moves into the cell, potassium moves to the extracellular. Okay? The hydrogen is what's causing that metabolic acidosis. But the hydrogen moves to the extracellular, so we're going to draw a lab and we're going to have high potassium. But the potassium is just not where it needs to be. It's in the wrong place. So we're going to have high potassium levels. Okay? Once our blood sugar starts to decrease and our pH starts to increase, then this potassium will start to go back into its proper place and you'll get a true reading. That true reading for DKA is typically hypokalemia. So you're looking at your lab and it says hyperkalemia. But if once it starts to go back into its normal place, once we start giving insulin, bicarb to treat fluids, to treat the DKA, then you're going to end up with a patient that is hypokalemic. Okay. So as we're doing insulin, as we're doing fluids, we'll typically add some potassium into the fluids so that we try to manage the potassium as it's being shifted from place to place. Okay. So potassium supplement is necessary. I know it sounds strange. Cerebral edema, we just talked about this, and this is also due to fluid shifts due to the sodium and the potassium. Remember, dehydration, increase in intracellular fluid. We have to go slow. If we go slow, then the shift isn't going to be as fast, and our treatment is going to work with those fluids so that there's not so much of a fluid shift. Okay, so with all of these treatments, we go extremely slow to give the body time to catch up with the treatment and to work its way down nice and slowly. It's those quick adjustments that cause the cerebral edema. Okay. Anion gap. This is often a test that you'll see with someone with high insulin values. This helps us measure to determine if it's an indication possibly of acidosis. Okay, it's not fail-safe. But what it does tell us is if someone needs to go on a regular insulin drip. Okay, so if it's greater than 17, then chances are what we're going to do is we're going to put this patient on an insulin drip. Okay. The anion gap is a measurement of sodium minus, it's a chloride plus bicarbonate minus sodium equals the anion gap. Okay, normal range is 3 to 15. It can be caused from other things as well, lactic acidosis, renal failure, and some poisonings. But in this particular case, we're just talking about DKA. So our treatment for DKA, this patient is in the ICU. We are going to give oral fluids if possible. Remember, they're dehydrated. We're going to give a fluid replacement to counteract the dehydration and hyperosmolarity. Right? Think of that hyperosmolarity. We're going to give regular insulin IV. This is a continuous slow drip. This will be given until the blood glucose is 250 or less. Once the blood sugar gets to about 250, then what we're going to do is we're going to add a sub-Q insulin. We're going to stop the drip and we're going to add the sub-Q insulin. And then we're going to monitor the blood sugar and try to maintain it like we normally do with our sliding scale, Lantus, prandial doses. Okay. We can also give sodium bicarbonate to reverse the metabolic acidosis. They try not to do this. We'll go over the medications below, but it is there if necessary. It is alkaline, so it's going to help decrease that acidosis. I have some of the chemical equations here for those of you who prefer to look at them this way on how the keto acids build up and the CO2 is elevated and so on. Okay, and here's a nice diagram showing you what we learned last semester with the liver, the starvation, so it starts to use the fat, which turns into fatty acids, and then we get ketones in the blood. Okay. All right, so HHS, we also spoke about this last semester a little bit, and this is the complication, short-term complication of type 2 diabetes. This is actually more common than DKA is. And yet sometimes the symptoms are just as bad, if not worse. The reason that it is more common is that it's not noticed as much in the early symptoms of it, and type 2 diabetics don't always check their blood sugar every day, depending on where you are on that type 2 diabetic scale. And so this would start happening without them necessarily knowing it. Okay, so it is a mild ketonuria can be present, severe hyperglycemia, hyperosmolarity, and then dehydration. Okay, the hyperosmolarity is due to the increased blood glucose. The intracellular fluid moves into the extracellular fluid. Okay. So the extracellular fluid volume increases, which causes cellular dehydration. Okay, so this is cellular dehydration. Let's see here. Because they have endogenous insulin, type 2 diabetics usually block that fat breakdown, so therefore they don't get ketones. This is why they don't go into DKA, is because they have this endogenous insulin. Okay, polyuria still occurs just because of that osmotic diuresis, because we have the hyperosmolarity that causes our dehydration. So it's just a constant flowing of fluid out of our body. Huge dehydration. Metabolic acidosis can be present when the when patients can have a non-ketotic HHS. Okay. Um, Now, to describe HHS, we've got a blood glucose greater than or equal to 600. Okay. Uh, this is elevated because it takes longer to get there, and the adverse effects don't happen as quickly as DKA. They happen slower, so that blood sugar tends to be higher. Our pH is less than or equal to 7.3, and our bicarb is less than or equal to 15. Our blood osmolarity as well for HHS is greater than or equal to 320, so we're very osmotic. 25% of patients present in a coma. So where DKA patients will come in with signs and symptoms of DKA and not typically present in a coma, 25% of the HHS patients will present in a coma. That's due to the blood hyperosmolarity in the brain. Our electrolytes, just like our DKA patients, are falsely elevated because of the dehydration, and so our potassium replacement is necessary. Again, very slow with this treatment. So slightly different with DKA on the treatment. We want to do fluid resuscitation first, then IV regular insulin. So if insulin is administered before the fluid resuscitation, that extracellular water will move into the intracellular, worsening the hypotension and possibly going into hypovolemic shock. Okay. Fluid also containing glucose is given once the IV regular insulin has stopped. That is to slow down the process so that they don't start getting so that they don't go too hypoglycemic. Okay. So again, in HHS, once the blood glucose reaches 300, this is a different value, then we're going to start insulin sub-Q, and we might start a slow dose of glucose-containing fluid, maybe probably D5W, depending on the sodium, because the sodium is going to be falsely increased, or we could give a low dose of normal saline to offset that electrolyte imbalance. Okay. Upper GI bleed. So we spoke about esophageal varices prior to this, and we know that that is one major cause of upper GI bleed. And then there are numerous other issues that can cause upper GI bleeds. One of the most prevalent being a peptic ulcer disease. So if we have an ulcer in our GI system, that can cause a GI bleed. So it's a rupture or tear, perforation in the esophagus or gastric lining. It can be mild to severe. The blood loss can be slow or fast, hopefully slow for the patient's sake. We're going to see a decreased hemoglobin and hematocrit, decreased plasma volume because of fluid loss with bleeding, increased BUN caused by dehydration, and digestion of blood. So the blood that is bleeding internally will become digested, and that in itself can increase your BUN. Hypotension, hypovolemia, and can eventually lead to hypovolemic shock. So when the upper GI bleed is mild, we can usually go and do a GI bleed, do an upper GI endoscopy. They can cauterize it. Sometimes it just clots by itself. Our job is to monitor the bleed, monitor the blood pressure. Okay, sorry about that. I got distracted by my husband and lost my train of thought. So, let's keep going. Upper GI bleed. So, of course, our job is to monitor the hemoglobin, hematocrit, signs and symptoms of bleeding, is the patient symptomatic or not? A lot of times, uh, signs of bleeding and being symptomatic is one of the reasons why they actually treat. Okay, and for the most part, we don't typically treat unless your hemoglobin is around 8. Okay, 8 or less, I would say. Now, when we're talking ICU, when we're talking active bleeds, so active bleed is going to be noted as a severe decrease in or in constant decrease of hemoglobin hematocrit. It's also going to be shown by actual frank red blood showing up somewhere, whether it be from their anus or vomiting. Um, and hypovolemia, hypotension. These are all signs that there is an active bleed. An active bleed needs to be in the ICU. As I've always said, or told you guys, remember that whole 2 minutes about blood circulating the body? That is why we can bleed out in about 2 minutes. Sometimes when it is a fast upper GI bleed, there's nothing that you can do. They are going to bleed out and go into hypovolemic shock. This patient is going to have rapid IV infusions of fluids, normal saline, to increase their vasculature system. They're going to have multiple blood transfusions. When someone is actively bleeding and you don't know where it's coming from, you can't treat it. You can just hope that by keeping you stable for a while, giving you platelets if need be, giving you the blood, giving you the fluids, that your body will take care of itself. So as you can see, this is a very grim outcome for this patient who has a fast bleed. We see GI bleeds all the time in the hospital. Most of the time they're a slow bleed, they can treat them, they heal by themselves. But we never want to take our GI bleed patient lightly because they can easily hit this threshold and start actively bleeding. Think about a cut that you have on your hand, or you're taking an IV out of a patient that's on Coumadin. It takes a long time to stop that bleed, and we're just talking about a vein, not a huge bleed in the GI system. Okay. Sometimes if you just let that IV bleed, it will just continue to bleed. You have to put pressure on it. You have to stop that bleed from occurring. So anyway, I just wanted to really articulate that this is... So as you know, what we can do as well is obviously try to treat the specific cause of bleeding. Omeprazole, a proton pump inhibitor, sucralfate to coat the gastric lining. These are all things that we can do to help prevent the bleed from progressing, from the peptic ulcer from causing the bleed. So when someone has peptic ulcer disease, it doesn't really seem like it's such a big deal, but the consequences of not treating it can be life-threatening. Okay? All right. So we have, I just put a little list down here. We have the ADH for diabetes insipidus, NSAIDs, indomethacin for DI, DKA, sodium bicarbonate. We're going to use sodium replacement, Lasix, tetracycline, IV insulin, which is always regular, remember? We can't use any other type of insulin for IV infusion. Fluid resuscitation, that could be in the form of D510 if we want to dilute the electrolytes, or slow normal saline if we need to increase them mildly. Electrolyte replacement, I have HHS here, but that really goes for DKA and DKA as well as SIADH. We have our vasopressor, which is desmopressin, which is that DDVAP, or Sandin or octreotide. Oh, I don't think I mentioned this above. I'll talk about it below. We talked about it last semester as well. Blood pressure. So for GI bleeds, varices, or possibility of GI bleeds from peptic ulcer disease, we want to keep that blood pressure low or lower so that there isn't that increased force causing a bleed to occur. Okay. Blood transfusions, and then the vasopressin antagonist. This is the Vaptan medications. The conivaptan is only in IV form, whereas the tolvaptan is in PO. Okay, and what I've done is I just put a little bit of a chart here because these are somewhat newer medications. You might have heard of some of these medications in OB actually, like indomethacin, desmopressin. These are used in OB as well as sometimes in peds. So let's see here. So our ADH, our vasopressin, which is our desmopressin, produced in the hypothalamus, stored in the pituitary. So this raises blood pressure by narrowing the blood vessels. It's a vasoconstrictor, so it helps in the control of bleeding due to the rupture of esophageal membranes. Okay. So this can be used for DI, for the bleeds, and then sometimes for CPR, depending on the necessity. It decreases blood flow to the peripheral and increases blood flow to the brain and the heart. Complications is that it reabsorbs too much water. Also MI from excessive vasoconstriction. And we do have some interactions with carbamazepine, and then the use of alcohol, heparin, lithium, and phenytoin decrease effects of the medication. Our nursing administration monitoring for, because this does fluid changes as well, we want to monitor our vital signs, our I's and O's, our urine-specific gravity. We want to monitor the IV site if it is an IV administration for extravasation of the site itself. You can have the desmopressin through a nasal spray, and we usually start that at bedtime. So will this increase blood pressure? Yes. What type of patients have GI bleeds? Peptic ulcer disease, esophageal varices. If a patient gets drowsy, we reduce the dose. Okay. So this is the vasopressin antagonist. So these are the two medications that the tolvaptans and the conivaptan. This is the antagonist of the vasopressor. So it increases renal water excretion and increases sodium, increased serum sodium, okay, which is what we want. When used with fluid restriction, does not. Actually, what we want to do here, this is written wrong, sorry. So we want to use this with fluid restriction. We want to try fluid restriction first. If it doesn't work, then we can try this medication. Okay. This should not be used when fluid restriction is occurring for the first 24 hours. Okay. Hyponatremia should be less than 125 for this medication to be used, and for SIADH. Complications is major hepatotoxicity for this medication. That's why they don't use it for more than 30 days. You're going to see hyperglycemia, polyuria, and anaphylaxis, but hepatotoxicity is the main reason that it's just not used generally. There are many interactions. Specifically, take a look at digoxin and how it might affect digoxin. We're going to monitor for neuro changes, fluid balance again, signs and symptoms of liver damage. We're going to watch for potassium because of the fluid shifts, and avoid fluid restrictions for the first 24 hours during administration. Okay, I'm going to highlight that. Avoid fluid restriction for first 24 hours while taking this medication. This medication is going to be given in the hospital at first, so that is something that as a nurse, if you don't have an order for, you would need to know. So, sandostatin analogs, octreotide. We use this for GI bleeds. It is an off-label use for GI bleeds and varicose bleeds. Okay, the documentation is not caught up with the amount of times that we use this. You're going to see this a lot. IV drip used to be only in the ER, ICU, but now it is all over the place. Okay, not a big deal. It reduces your gut mobility, gastric emptying, and splenic blood flow by inhibiting glucagon release. So what that does is if it decreases the splenic blood flow, then it's going to help the GI bleed heal by itself. Okay. Like I said, off-label use, however, it's used for this all the time now. Complications is just for prolonged use. However, for GI bleeds, this is going to be a short-term treatment, so we don't need to worry about prolonged use complications because this is only a short-term treatment. You need to, because it inhibits glucagon release, we need to monitor the blood sugar. They could become hyper or hypoglycemic. Also, an interaction is with antidysrhythmias. So what it does is it causes conduction delays, so we need to have them on a cardiac monitor. Of course, they're going to be on a cardiac monitor. They have a GI bleed, but just so you know, octreotide drip needs to be on a cardiac monitor. Okay. Oh, and I just talked about that. So our potassium, I haven't written anything in here because we've talked about potassium before, but basically when we need to adjust the potassium in these endocrine and diabetic DKA, SIADH very, very slowly, DI very slowly. So potassium less than 3.3, maybe hold the insulin. Administer potassium until it reaches greater than 3.3. Can be added into an IV bag, often done in DKA patients to try to offset that hypokalemia, which is true, versus the hyperkalemia, which is a false reading because of dehydration. Alkalizing agents, the sodium bicarb. So this is just an alkaline agent, neutralizes acid. Purpose is to decrease that increase the pH for severe hyperkalemia and acidosis. Okay. Complications is you can over-medicate and cause metabolic alkalosis. So lots of ABGs being done here. Interactions are with ketoconazole as it decreases the absorption. And as far as administration for sodium bicarb, we need to administer with potassium chloride in that bag. We're going to reevaluate every 2 hours until pH is greater than 7 or the anion gap is normal. Remember that anion gap from above. We are going to change the pH slowly as ketones. So ketones, what they do with bicarbonate is they decrease. So that can happen too quickly. If the acidity decreases too quickly, then the cerebrospinal fluid, which is acidosis as sodium bicarb does not cross the blood-brain barrier. Okay, so in other words, the acidosis continues in the brain because the bicarb cannot get to the brain. So you might notice that their pH and their acidosis is decreasing, but now all of a sudden they have mental, neurological changes because the bicarb cannot get to the brain, and so the brain is acidic. So we have to do that, switch over that fluid adjustment very, very slowly in order not to get the cerebral edema from the acidosis from the cerebral spinal fluid. And very complicated, but kind of fun at the same time. Not for the patient. And then the tocolytics, indomethacin. This we use as an NSAID for DI, works with the ADH. The action actually is kind of unknown, but it does inhibit prostaglandins, but it's unknown how it affects the ADH. This is another medication that you might see in your OB and peds. It's a little bit off-label for DI, but apparently works very well. Never seen it used myself, but it is part of the regular treatment. So the purpose is to decrease inflammation. Mechanisms of action are unclear for DI. Complications are GI bleeding, hypersensitivity. So if you have DI and you have a GI bleed, you're out of luck. Interactions are increased bleeding with anticoagulants, hyperkalemia with potassium-sparing diuretics, and lithium toxicity. And because it is that anti-inflammatory, it is an NSAID, our major nursing administration to monitor would be bleeding. So you're going to look and monitor for bleeding just like you would with ibuprofen. Look for blood pressure changes, hemoglobin, hematocrit, all the things that come along with a GI bleed. Okay, so let me just kind of review a little bit. I'm going to move it up all the way here. So we've got our SIADH, which is fluid volume excess. So it's dilutional natremia. So we have to increase the sodium very slowly, and we will typically try to do that slowly with normal saline. Okay. We need to monitor fluid shifts and blood pressure. Our electrolytes are going to be, some of our electrolytes are going to be falsely low because of the dilution. Diabetes insipidus, it's a low ADH. This is the opposite, so we have fluid volume deficits. So they're dehydrated, low blood pressure. This causes our electrolytes and our sodium to be increased. So we have hypernatremia. The best way to take care of the hypernatremia would be the D5W, okay, to dilute the sodium in here, which will bring the sodium level down. Okay. Diabetes insipidus, treat with D5W and desmopressin. So we want to replace that ADH. SIADH, we need to get rid of some of the fluid by not but while not decreasing that sodium too much. So Lasix, as we know, will flush out our sodium, so we need to give it with hypertonic saline in order to keep that balance or even increase the sodium level slightly, so we can get off water and increase the saline, the sodium at the same time. We fluid restrict because we don't want to dilute the patient any further, but if fluid restrictions and these other don't work, then we can go to the ADH antagonists, which are conivaptan and tolvaptan. These are not recommended because of the severe injury to the liver that can be caused. And remember the slow increase in sodium, 10 to 12 millimoles in a 24-hour period. DKA, caused by starvation because of the glucose is not getting into the cells, and so we start to break down our fatty acids, which causes ketoacidosis. We're going to have a high false high potassium level. Initially, type 1 diabetics most of the time have a very high mortality rate if they start to get cerebral edema. Unfortunately, it takes on average about 7 doctor's visits to have type 1 diabetics actually diagnosed. So a fair number of diabetics can have some cerebral edema when they go into the hospital. And anion gap is to kind of give us an indication of acidosis, but what we use it for mostly is to make a decision on whether or not the patient needs to be on an IV regular insulin drip. Okay, so we need to replace fluids, oral as well, if possible, to counteract the dehydration and decrease the hyperosmolarity. Regular insulin until blood sugar reaches around 250 or less. Then we're going to convert them to sub-Q insulin. And then sodium bicarbonate to reverse metabolic acidosis only if necessary. HHS is the major complication of type 2 diabetes, which is severe hyperglycemia, hyperosmolarity, and dehydration. Typically, no ketones are involved here because the patient has endogenous insulin. They could get some mild metabolic acidosis, but not typically. Blood sugar is always much higher in HHS when it becomes when they go into HHS than DKA because of their endogenous insulin. Again, electrolytes are falsely concentrated, so we also do need to replace potassium, but also with fluids. So we can give a small amount of potassiums with their normal saline, let's say. IV regular insulin as well can be given, and then switch over for HHS once it reaches 300. Upper GI bleed. Major note on this would be to monitor that hemoglobin and hematocrit, blood pressure, and look for active bleeding. Active bleeding should never stay on a regular floor. Even a step-down unit needs to go to the ICU. Very fatal with hypotension, hypovolemia, and then hypovolemic shock. We want to think perfusion, gas exchange from extra fluids because it's going into the lungs, and so gas exchange can be diminished. If a fast upper GI bleed happens that causes the hypovolemic shock, hypovolemia, hypotension, then rapid IV infusion, multiple blood transfusions to try to correct that issue, possibly platelets as well. We want to be cautious with our PUD patients because we don't want this to happen to them, so that's why we give them the omeprazole and the sucralfate to help protect that GI tract so that the ulcers don't break through and cause the bleeding. Okay, quick little review. Hopefully this was helpful. I'm going to press finish now, and I will see you on Friday.